And I'm Francesco Passamonti from the University of Milano in Italy. And today we want to discuss about a new compound. The name is nuvisertib, but basically to this new mechanism of action in the field of myelofibrosis, that is the PIM kinase inhibition. So basically we know that nowadays we have a standard approach to myelofibrosis that is based on stem cell transplantation and on JAK inhibitors. And the mechanism of action of the JAK inhibitor is basically an inhibition of the JAK-STAT pathway, partial inhibition of the JAK-STAT pathway. From the clinical point of view, we demonstrated that we can reduce splenomegaly, improve symptomatology, and with some agents with survival data in the long-term follow-up, we've also demonstrated in the retrospective analysis and subgroup analysis that this JAK inhibitor can induce an impact on overall survival that is, of course, not huge. Some of these JAK inhibitors can induce an amelioration of hemoglobin. The four molecules are ruxolitinib federative that are approved in US and FDA by many years in patients with intermediate high-risk myelofibrosis with a platelet count more than 50,000. Momelotinib that is approved in US and Europe with the indication of patients with myelofibrosis and anemia, first and second line as well. And pacritinib that is approved for patients with intermediate and high-risk myelofibrosis and a platelet count less than 50,000, basically in US and not yet in Europe, but we have the Pacifica study that is an ongoing clinical trial testing pacritinib versus best available therapy in patients with a very low platelet count, so less than 50,000. So basically, these agents have a similar mechanism of action. Two of these include also ACVR1 inhibition that are pacritinib and momelotinib that can induce amelioration of hemoglobin. But of course, we know that we need other mechanisms of action for patients who are ineligible for JAK1 and JAK2 or for patients who relapse after failure of JAK inhibition. And today we have some new agents that act against specific targets. For instance, ROPEG interferon is now under investigation in myelofibrosis in those patients with IPSS, DIPSS, low risk, and for those patients with prefibrotic myelofibrosis. And we have some data from the phase 2 study presented at EHA, and we have to wait the result of the ongoing phase 2 study. We have also the telomerase inhibition that the target is, of course, telomerase. Metastasis is the name of the drug, but the study is still ongoing. The BET inhibition is the area that is of great interest in MPN and MDS as well. Pelabresib is the one compound, and Professor Vannucchi will present the result in JAK inhibitor naive patient of the combo JAK inhibitor plus pelabresib just after me. And there is another JAK inhibitor that is another compound that is in development, some data presented at the last EHA meeting. Then we have also PIM1 kinase inhibitor, and PIM1 is, as we will see thereafter, a downstream effect of the JAK-STAT pathway. The name is nuvisertib. And besides this, we have also other two important mechanisms of action new that are the MPN inhibition. The name of the drug is navtemadlin, and also the XPO1 inhibition. The name of the drug is selinexor. And these two compounds are under investigation in the JAK inhibitor naive patient, selinexor, and JAK inhibitor naive patient who receive ruxolitinib and who are in suboptimal response. And in this setting, the name of the protocol is poiesis. So basically, the PIM1 kinase inhibitor are a novel class of therapies that have reduced the hematopoietic cancer cell proliferation. This has been demonstrated in different diseases and also in myelofibrosis, and increased apoptosis in preclinical models. And so basically, we want to present now some preliminary safety and efficacy results coming from phase 1-2 study. So PIM1 kinase are downstream targets of the JAK-STAT pathways, as I said earlier. You can see here the representation of the JAK-STAT pathway, the PIM kinase. And the expression is upregulated in myelofibrosis and modulates cytokines involved in immune activation and fibrosis. And we will see, this is very critical because we will see in clinics also an effect of the compound versus fibrosis and versus immune activation. And PIM1 kinase inhibitors have been shown to reduce proliferation and increase apoptosis of cancer cells, and this is the reason why the drug is active in myelofibrosis. Nuvisertib is the first-in-class selective PIM1 kinase inhibitor that has been investigated in an ongoing phase 1, phase 2 clinical trial as a monotherapy and ongoing in combination with JAK inhibitor, ruxolitinib in one arm, momelotinib in the second arm, for those patients who are relapsed or refractory to myelofibrosis. And preliminary data has been presented at ASH meeting 2024 and very recently at EHA meeting in Milan 2025. And here, the result of the monotherapy has been presented in patients who fail JAK inhibition and also in patients who were ineligible to JAK inhibition. So this is the design of the study that is an ongoing phase 1, phase 2 trial. This is an open-label, multi-center that investigates the safety and efficacy of nuvisertib as monotherapy or in combination with JAK inhibitor therapy. First of all, which are the patients enrolled in the clinical trial? Primary or secondary myelofibrosis. Patient can receive one or two JAK inhibitors. For some of these receive ruxo, and some other receive ruxo and federated, for instance, so second line or third line therapy. Patient need to be in intermediate 1, intermediate 2, or high risk condition. Platelet count more than 25,000 for those patients belonging to the arm 1, that is the nuvisertib monotherapy, and more than 50 for those who receive nuvisertib on ruxolitinib or on momelotinib. Of course, patients need to have a light splenomegaly and at least 2 measurable symptoms according to the MPN SAF version 4.0. This is a dose escalation phase, ERM1 nuvisertib single agent in those who are relapse resistant or ineligible to JAK inhibition, and then a phase of expansion and the arm2 combining ruxo plus nuvisertib. And this patient need to have received ruxo for at least 6 months and need to have a stable dose of ruxo for at least 8 weeks. And the new arm3 combining nuvisertib plus momelotinib. And for those patients who receive JAK inhibition, of course, not momelotinib and anemia. So this reflects the current indication from ruxolitinib. The primary outcome of this study was, of course, this is a phase 1/2. So DLT incidence and treatment emergent adverse event and SVR35. So these are the results. And these are the results in terms of spleen and symptoms, spleen on the left. You can see here the best spleen volume response in 18 patients with available the evaluation of the spleen. So these are patients who completed more than 20 weeks of treatment and or discontinued due to adverse event. You can see here that overall spleen volume reduction was obtained in 67% of the patients. Very few of these patients are resistant to nuvisertib in terms of SVR. And the SVR more than 25%, so SVR 25, we have to consider that SVR 25 is a good endpoint for those patients who fail JAK inhibitors in the first line, so for the second line setting. And this SVR 25 has been achieved in 22.2% of the patients. So basically 1 out of 5, 1 out of 4 patients achieve SVR 25. And concerning symptomatology, we have information about 18% that are available for this endpoint. And basically, we can see that vast majority of the patients, so 61% of the patients, achieve a reduction of total symptom score, and TSS 50 was achieved in 44% of the patient. And remember, this is a condition of resistance and tolerance to one or more JAK inhibitors. And so the first idea, of course, looking at this estimate of trend is the stability. So we can see here that there is a stability of hemoglobin and stability of platelet during the treatment. And this has been tested in 77 patients of the whole course of patient. But you can see here important information about a cohort of patients who were anemic at baseline, so less than 10 gram deciliter. And the mean hemoglobin improvement of more than 1 gram deciliter for more than 12 weeks without transfusion was observed in 1 out of 4 patients who are anemic at baseline, so with hemoglobin less than 10 gram deciliter. So we have seen efficacy in terms of hemoglobin improvement in those patients who are anemic. The second point is on platelet, and in the cohort of patients with less than 100 platelet count, you can see that there is an improvement of patient platelet, more than 30,000 for more than 28 days without transfusion in 26.7% of the patient, basically 1 out of 4 patients. And if you look also to some biological effect, and we have data on 28 patients who receive a baseline bone marrow evaluation and then at least one post-baseline bone marrow evaluation. You can see here that 42% of the patients achieve an improvement of bone marrow fibrosis, and 50% of the patients, the bone marrow fibrosis remain unchanged. And of the interest from my point of view is the association between bone marrow fibrosis reduction and some clinical parameters. And we note that 50% of the patients achieving bone marrow fibrosis improvement achieve also TSS 50, 50% SVR25, and 41% of the patients achieve both anemia and platelet response. Of course, this is not a huge number, but is on 12 number of patients. So what about toxicity? As expected, most of the toxicity was on GI, so diarrhea, nausea, vomiting, accounting for 53%, 40%, 29% of grade 1. So most of these are grade 1. So if you look at grade 3 GI toxicity, this is very rare. So basically diarrhea in 5% of the patient, nausea 1.3% of the patient, and no vomiting. And also the other events was very, very rare. But consider, of course, also hematological toxicity. So a decrease of the platelet count in the name of thrombocytopenia grade 3 has been achieved in 16.9% of the patient, and anemia 13% of the patient. And consider that we have a high rate of patients with a very low platelet count and very low hemoglobin level. This is in relation to the first information we discussed about the new mechanism of action. So we expect to have an effect on some cytokines, and we have also to have the full lineage. So effect on cytokines and association with clinical parameters. So basically, we found that there was a modulation of pro-inflammatory cytokines and anti-inflammatory cytokines that have a final impact on the clinical advantage in terms of symptom and splenomegaly. So for instance, we have a decrease of pro-inflammatory cytokines such as NRAGE and NIP1 beta. And these cytokines have a role in neurotrophic chemotaxis, in inflammatory response and cellular response. And within this study, we found that a decrease of NRAGE that is associated with a reduction of fatigue and night sweats, and a reduction in NIP1 beta was related to a reduction of fatigue, night sweat, pruritus, so important symptoms, but also an improvement in SVR, so on the response of the spleen. And we also demonstrate that there is an increase in anti-inflammatory cytokines. One among all, the effect on adiponectin was very significant. And the adiponectin is correlated to an inflammatory response, so the regulation of the inflammatory response, and also on regulation of signal transduction. And in the study, we found a correlation between an increase of anti-inflammatory cytokines and a reduction of symptoms such as early satiety, rib pain, abdominal discomfort, and increase in the response on the spleen. And again, also a reduction of bone pain and increase of SDR in the case of interleukin-8 improvement. So basically, we demonstrated cytokine modulation related to nuvisertib and the correlation between the cytokines regulation and the symptomatology improvement and the spleen volume response. So this is the summary of our presentation. So the new mechanism of action of PIM1 kinase inhibitor, of course, may offer an alternative treatment option for those patients who fail JAK inhibition. So the mechanism of action is different. And so we can use this drug as single agent in those who fail JAK inhibition, or adding on to JAK inhibition in the case, for instance, of suboptimal response, just to see if downstreaming targeting the downstream of JAK2 and targeting JAK2 as well may be beneficial for the patient. And nuvisertib, that is a first-in-class PIM1 kinase inhibitor, has shown promises resulting in terms of safety and efficacy in this phase 1/2 study. And to summarize, this spleen size was reduced to more than 25% in 22.2% of the patient. The TSS more than 50% in 44% of the patient. And we also saw demonstration of a significant cytokine modulation and an association between cytokine modulation and clinical improvement. Basically, no dose-limiting toxicity has been observed, and overall nuvisertib was well tolerated. And today, the ongoing phase 1/2 study has been expanded to assess nuvisertib in the arm 2 and 3, as we said, in combination with Ruxo arm 2 and in combination with momelotinib arm 3. And this is a very recent information about the EHA 2025 that nuvisertib has been granted orphan drug and fast track designation by FDA for the indication of myelofibrosis. And this, of course, is good for the compound and potentially good also for patients. So I think that these are the 4 points that I think are of interest for this discussion. So we have seen the mechanism of action of this PIM1 kinase inhibitor. And so overall, how do PIM kinase inhibitor address current unmet needs in myelofibrosis? So if someone of you want to comment on this. We discussed the mechanism of action. The information today is that this is a downstream target. There is evidence of a modulation of cytokines and also in involvement of immune activation and fibrosis. So basically, do you think that this is a good mechanism of action that covers some unmet medical needs in myelofibrosis?
Francesco,
Yeah.
can
Professor
you hear me?
Absolutely.
Yes.
Well, yeah.
So you mentioned that the drug is used in those patients who have suboptimal response. What do you mean by suboptimal response? Because you have many possibilities to say suboptimal. And I wonder whether the results are according to the different pattern of the suboptimal definition. Can you expand this?
Yeah. This is an excellent point. So basically, the result I presented was on patient who failed ruxolitinib or ruxolitinib and fedratinib. So the result on patient considered suboptimal by the investigator are not presented today because these represent cohort 2 and 3. So the combos nuvisertib plus momelotinib, nuvisertib plus ruxolitinib. And so the criteria for defining suboptimal in that cohort was patients who have not achieved a very well control on symptoms, spleen, or received transfusion, for instance. So the currently criteria for the definition of suboptimal. But the information I discussed today was on those patients who failed, so not suboptimal.
Hi, can I say something?
Absolutely, thank you.
Yes, it's very interesting. I have a question quite coming to the same point. As you said, it is for refractory and relapsed MF, mainly refractory to RUX. So I have two questions to arm 2 and arm 3 because I don't know the rationale. Refractory patients for 6 months on RUX and then adding, we don't usually keep patients that are refractory more than 6 months if they don't respond. This is for arm 2. I don't know what the rationale, because again, it depends on the definition of a refractory in the trial, sure, because it is different from suboptimal. And the second question to arm 3, as we know that momelotinib is usually approved as with platelets as low as 25. So do you know why with the combi, now the baseline has to be at least 50,000 because, the real and unmet is this group of patients, refractory, we change to momelotinib with anemia, and particularly if they have low platelets. So I don't know what the rationale was behind that.
Okay, I just want to report the result in those patients presented today. So these are the patients who received nuvisertib phase 1 part. And just to comment on the disease characteristics that I have not shown, but just to say why the study included patients who are resistant. So basically, the spleen volume in this patient was 1,936. So basically a huge spleen. By palpation, the medial value was 12 centimeters for the left costal margin. The total symptom score, TSS, was 23, so particularly higher, comparable to other clinical trials in the second-line setting. And the rate of patients who have a hemoglobin less than 10 gram deciliter was 22%, and 30% of the patients enrolled in the clinical trial, including patients who are transfusion dependent. So most of these patients, 82% were DIPSS intermediate 2 and high, and 41% of these patients had a high molecular risk. So this is the cohort I presented the result today. So that's the point, and thank you, Tiziano, again for having underlined this point, but I think that this really reflected the condition of resistant and intolerant because these are patients with huge spleen. Most of them are anemic. 1 out of 3 are transfusion dependent, and 40% have a high molecular risk disease. So the second question is on patient and the add-on. So patients who are on ruxolitinib or on momelotinib and have a condition of resistance or intolerance of suboptimal. I think basically that we are developing many new mechanisms of action, and we know that the PIM1 inhibition may be downstream to the JAK pathway, and so this, of course, may complement the activity of the JAK inhibitors. So basically, I think that the rationale is to go to the downstream and have a more potent inhibition. So I think that basically this is the rationale of the combination. What do you think, Haifa?
Yes, but the the unmet need is mainly, you know, I still don't understand if I have a refractory patient after 6 months, particularly now with the availability of the drugs. We're not, you know, it is a little bit challenging, if I might say. And nuvisertib is not known to cause that much thrombocytopenia. You showed it nicely. And I was wondering why in the momelotinib combi, they are requiring a baseline platelet count of at least 50 instead of the usual 25. Because I know originally when they were thinking about designing the trial in combination momelotinib with the PIM3 kinase inhibitor, they didn't exclude any platelet counts, even severe thrombocytopenia. Yeah. So that's why I'm wondering now.
This is a very important point, I think. I fully agree with your comments. So basically, so I agree to not consider patient platelet count 25 to 50 in any combo, because of course a JAK inhibitor, momelotinib per se, may reduce platelet count. About 15–20% of the patient have a reduction grade 3–4 platelet count toxicity. So we know that also momelotinib and also pacritinib can reduce platelet count. So basically, also nuvisertib can reduce platelet count 16.9%. So if you think that combine a JAK inhibitor with another drug, I think that is more safe to keep a platelet count higher for patients. This is my personal point of view. Because we now have not to forget that any JAK inhibitor, basically, if it is a JAK inhibitor, reduce platelet and hemoglobin. And this is true, especially for Ruxon, federatinib, but this is true also for pacritinib and momelotinib. Basically, I think that in a combination, it is much more prudent to keep patient in the trial with a higher platelet count. This is, I think, very prudent. Do you agree with this, or do you think that is not?
Sure. I just wanted, you know, to have my thoughts. Thank you. I fully agree, and I cannot change it. I have no influence.
Basically, we know that if a patient started with Ruxo and became anemic, we can use momelotinib as single agent. But of course, this is our MPN community of research that say, okay, we can do something more. For instance, we have momelotinib plus luspatercept in those who are transfusion dependent. This is the Odyssey. This is another momelotinib plus nuvisertib with idea to improve also spleen, to improve also symptomatology. So this is basically an unmet medical need. So why not?
Sure. Thank you. Thank you.
Steffen?
Sorry, I was muted. Sure. Thanks, Francesco, for this interesting data. My question would be, is there a way of measuring PIM kinase activity in patients receiving various treatments, under certain treatments like ruxolitinib, for example, to identify those that still have, despite JAK inhibition, still have PIM kinase activity? And shouldn't these patients be the first ones to treat and to look at response? And maybe linked to that question, has that been assessed in the study to look at PIM kinase activity by reporters or whatever to know which ones have the highest chance of still having high kinase activity and then responding to PIM kinase inhibitors?
I think this is a very nice question and very important. So for the time being, you have not yet this information. You know that I'm not an author of this study, okay? So I just report the result here for our discussion. Basically, I think that you are right. And I think that the company has collected the samples for answer your question, but for the time being, I have no answer for your question. But I think that is very right, because in the future, we have to personalize the treatment of our patients. So to have this information may guide our choice for the future. Thank you for the comments, Steffen.
And I am also asking because PIM kinase, PIM1 is a direct target gene of STAT5. And we know that JAK inhibitors inhibit STAT5, but they may not be inhibiting it completely. So I think we would have a better chance of finding right patients by looking at those downstream effects.
So other questions? We have reported this other question. So how might the data from the phase 1 study on nuvisertib monotherapy impact the clinical practice? So I think that this is an option, a single agent, if a patient failed the available JAK inhibitor. So if a patient failed ruxo, failed momelotinib, failed fedratinib, we have this information with the nuvisertib. We can improve the spleen symptoms, stable hemoglobin and platelets. So that's an option. If this, of course, will demonstrate to be impactful in the future. And so in my view, of course, there is a signal of activity. And if one patient failed the 3 other JAK inhibitor, or we have no expectation of improvement by one of the other JAK inhibitor, in the case, for instance, a patient start with ruxo, failed for anemia, start momelotinib, failed for anemia. Of course, I think that fedratinib is not suitable for a patient with this profile. So in the future, we can use, for instance, nuvisertib as the patient has anemia. But of course, we have to wait the result, for instance, of independent study that will arrive very soon of luspatercept. We have also a retasertib. We will have a retasertib in terms of just anemia improvement. But the characteristic of this compound is to be more active in anemia and also spleen and symptoms. So that's my opinion. But of course, we have to collect more information, longer follow-up, and so on and so on. Someone of us want to comment on this point?
I think the comment of Haifa Kathrin before is also important. We can target thrombocytopenic patients also. Seems quite safe. And also very symptomatic patients. That's maybe a strength of this compound, those who respond on the spleen but remain with a lot of symptoms, especially those linked to cytokine, as you showed nicely, the reduction in a various number of cytokines. So symptomatic patients, thrombocytopenic patients may probably be good candidates for this agent.
Other comment? And the point number 3 is the benefit we expect by the combination. So my personal view is that momelotinib demonstrated to be active on hemoglobin, spleen, not so much on symptoms, either in the first and the second line setting. So adding on, we can improve anemia, of course, again. We can probably improve spleen response and symptom response. So this is my expectation from a clinical result of this combo. What do you think?
I may have missed this earlier on, but is there preclinical data to say that the combination is better than each individual therapy? I mean, we know the individual benefit, at least from the phase 1 data for nuvisertib, and we know the JAK inhibitors, what they can do. But is there any kind of additive benefit of putting them together, or is it multiplying their effect?
I think that there is information in preclinical data that we expect to have this, and also by the combination. So there is information about the combo with JAK inhibitors, and I think that basically the most of the information will come from the clinical association. So
I apologize for being late. I had an unavoidable thing come up, but so I missed your discussion, Francesco, but I would echo what Jean-Jacques said, Jean-Jen said, which is that a lot of patients are referred, at least to me, when their symptoms persist despite JAK inhibitors. So they may not be officially refractory, but they've had their primary problem is in quality of life. So if we see improvements with that STAT inhibition that is truly impacting their symptoms, I think that's a very strong way to address people that might not meet the official criteria for relapsed refractory, but in whom they could get benefit from the combination. This may be something you already talked about. It's just I'm sure many of our experiences is many referrals that I get are when they've tried one or two and they just remain highly symptomatic.
This is, of course, the maintenance of symptomatology is a clear unmet medical need for some patients, because we know that Ruxo is able to control symptomatology, but just not in the long term. So I have enrolled some patients in this clinical trial. I've seen that the symptomatology, the effect on symptoms was clear in patients who failed the control of symptomatology, at least in the patient I enrolled. So the last question for our discussion, because we have just 1 minute, is how might data from the expanded phase 1/2 trial of nuvisertib in combo with JAK inhibitor and resistant refractory MF impact our clinical practice? Of course, this is a question for an advisory board more than this for this scientific community. But basically, I think that we have to wait the results, because the combination depend, from my point of view, the line. So JAK1 inhibition first, second line combo, or JAK line inhibition plus something other target in the first line, and the same in the second line. So it depends mainly by the line of treatment of the patient, depend mainly by the problem of the patient. So if the problem is symptomatology, cytopenia, potentially this combination may be in fact impactful. Otherwise, we have also to have other information, such as the variation of the clones during time, emergency of other clones. So I think that for this combination, so JAK1, JAK2 plus other target, we have to ask for clone variants, the VAF variation during time. So I think this is quite important. If we do not have this information, basically my expectation is to improve something in the disease, especially to improve symptomatology of patient, because this is a very important point for patient improvement of quality of life. But we have, of course, to wait for longer follow-up, wait for clone variations and so on before for me to be conclusive on this question number 4. What is your impression?
Can I, Francesco, all of this discussion we are having now is based on a limited number of patients already treated. So many of these questions, you cannot answer many of these questions because you don't have sufficient information to cover all the questions you are raising.
Absolutely. I absolutely agree with Tiziano, because we need to have more patients and a longer follow-up, and
yes,
we have to also collect the biological information. But if you, for instance, just looking at the results, okay, so the study with a few patients demonstrated that as a single agent, there is a reduction of the spleen, improvement of symptoms, stability of hemoglobin platelets, some reduction of bone marrow fibrosis. That's the point. So
yes.
I think that per se may be an option for some patients who fail other JAK inhibitors, because it's a different mechanism. That's my opinion.
Yes, yes.
Then the result of the combination is suboptimal response, need patients follow-up and response at the moment we have not. So absolutely, we have not to be conclusive on this point. So that's in favor of discussion. So the global impression of the data that we have as a MPN expert community So if the global impression of the data seems to be good, not good, that's I think that our mission as MPN expert community